move on to the last speaker of this session, who is Professor Renhua Lu from Shanghai. He is a member of the Peripheral Vascular Disease Management branch of the Chinese Society of Geriatrics, and he collaborates with many journals, and he also wrote books on care nephrology, technology of blood purification, internal medicine, diagnosis and treatment of diseases. He will present us the Shanghai expert consensus on clinical applications of hemoperfusion. Please, Professor Lu.
Distinguished guests, ladies and gentlemen, good afternoon. First of all, I would like to thank the chairman for the induction of mine, and thank the John Fong company to give me the chance here to take this presentation. So today I would like to talk about the Shanghai consensus on hemoperfusion in maintenance hemodialysis patients. First of all, I will show you the case, which is from our hemodialysis center. This patient is male, 60 years old. The diagnosis is ADPKD and chronic kidney disease 5-stage, received the maintenance hemodialysis and hypertension. The dialysis vintage is 220 months, and the symptoms with him including high blood pressure, pruritus, sleep disorder, and ostealgia. And the current dialysis prescription is HDF hemodiafiltration 3 times a week, and 4 hours for each session. So in this case, what can we do next? And this slide shows the data from Chinese National Renal Data System in this year. Shows that the number of MHD patients was 844,000 by the end of last year in Chinese mainland, and the increase of 3.6 times compared to 2011. And the number of new MHD patients was 56,000, and the total prevalence of MHD was almost 600 per million population in last year. So in this slide, we can see the number of MHD patients in Chinese mainland is increasing during the past 10 years. And this slide shows in our hospital. In Renji Hospital, the number of hemodialysis patients reached to 700 at the end of last year. And the average annual death rate is less than 5% during recent 10 years. Due to the COVID-19, the annual death rate reached to 10% last year. And as we know, the uremic toxin are the cause of high mortality. There are almost more than 200 toxins in ESRD patients. And the toxins can lead to the uremia syndrome, the structural damage, dysfunction of cell, tissues, organs, and metabolic disorders. So eliminating uremic toxins is the foundation of ESRD treatment. And this slide shows the classification and the markers of uremic toxins. As we know, according to their molecular weight, the uremic toxins can be divided into the small molecular, middle molecular, and the macromolecular toxins. And also we have the protein-bound uremic toxins. And it is well known that the principle of hemodialysis is diffusion. It can remove the small molecular toxins except the protein-bound toxins. And the principle of hemofiltration is convention. It can remove middle and macromolecular toxins. And the principle of hemoperfusion is absorption. It can remove the middle and macromolecular toxins, and also especially the protein-bound toxins. So if we combine with HD and HP or HDF and HP in series, it can remove more toxins. So there are 3 scientific questions, which is, can hemoperfusion combined with hemodialysis increase the elimination of uremic toxins and improve the quality of life of patients and reduce the risk of death? To answer these 3 scientific questions, we performed a multi-center open randomized control study in Shanghai. The study name is the efficacy of hemoperfusion treatment on improving the survival of maintenance hemodialysis patients. In this study, we totally involved 1,407 patients with maintenance hemodialysis. These patients were randomized, divided into 2 groups, and followed up for 2 years. In control group, there are 703 patients. These patients received the blood purification treatment 2 or 3 times a week, including hemodialysis or hemofiltration or hemodiafiltration. And in HDFP treatment, there are 704 patients. These patients also received the blood purification treatment 2 or 3 times a week. But in this treatment, in this group, these patients received the hemoperfusion treatment at least once every 2 weeks, use the HA130, which produced by Jiangfeng company. This is the study mass in the running period for including 4 weeks. In this period, the patients received the regular blood purification treatment, and the intervention period including 96 weeks. And the primary endpoint is mortality, including all-cause mortality and cardiovascular mortality. And the second endpoint is a new or recurrent cardiovascular events, including the myocardial infarction, severe arrhythmia, heart failure, and so on. And this is the result of this study. The all-cause mortality in hemoperfusion arm started to reduce significantly since the 24 weeks, and at the end of this study, it decreased 37%. Over time, the mortality gap between the 2 groups increased gradually. And for the cardiovascular mortality in hemoperfusion group was also significantly lower than that in control. Compared with the control, the cardiovascular mortality in HP group decreased significantly from 24 weeks. And also after 2 years follow-up, the new or recurrent cardiovascular events was significantly higher in control group than in HP group, and there are no difference of the other events like the cerebral vascular disease and so on. And for the quality of life, we use the kidney disease target area score. And we can see the symptoms and discomfortable and cognitive function, social support is improved in the treatment group. And also the SF33 life quality score is also improved in the HP group. And we also check the IPTH and beta-2 microglobin. We can see after treatment, the level of IPTH and beta-2 microglobin in the HP group was very low than the baseline. And also the decrease of IPTH and the beta-2 microglobin in HP group was significantly higher than that in control group after the end of the treatment. And for the safety, there was no significant difference in blood protein, liver function, the blood lipid, and blood glucose between the 2 groups before and after treatment. So the safety of the HD plus HA130 hemoperfusion is validated. So let's see the conclusion of this study. It is clear that the hemodialysis combined with HA130 hemoperfusion can reduce all-cause mortality and cardiovascular mortality, as well as new or recurrent cardiovascular events in patients with uremia. And the term of therapeutic effect is more obvious. And also it is further confirmed that HA130 hemoperfusion has the effect of reducing the IPTH and the beta-2 microglobin. And it is also confirmed that hemodialysis combined with hemoperfusion can improve the quality of life with uremia. And also a lot of reference indicate that the benefit of hemoperfusion combined with hemodialysis, including the improved CKD-MBD, improved the refractory hypertension, and also improve the restless leg syndrome, protect the radial kidney function, and so on. So based on these clinical studies, the Shanghai consensus hemoperfusion in maintenance hemodialysis was published in Shanghai Medical Journal in 2021. And it took 30 months, held 3 large scale expert consultation and finalization meetings, and including more than 14 Chinese experts. This is the summary of the consensus with reference to domestic and foreign literatures, combined with the clinical diagnosis and the treatment experience. The consensus on the clinical application of hemoperfusion in MHD patients was formulated in terms of 4. One is the indicated patients, the treatment frequency, the treatment mass, and the adverse reaction and the precautions. The first part of the consensus is the indication. The MHD patients have the following clinical symptoms recommended to the HP treatment, including 9. One is the severe uremia pruritus, severe uremia-related sleep disorders, and so on. And in the following slides, I will explain these indications in detail. The indication 1, the severe uremia pruritus. We also know the pruritus is very, very difficult to treat. And in this consensus, if the modified dose pruritus score more than 12 or the VAS score more than 8, it's recommended to start HP treatment. The modified dose pruritus, including the degrees of inching, the location, the frequency, and the number of attacks, and also for the sleep. And the VAS score and the modified dose pruritus score is high, which is higher is a score, so more serious of the pruritus. And the indication 2 is the severe uremia-related sleep disorders. So we also use the Pittsburgh Sleep Quality Index. If the PSQI score more than 10 points, it is recommended to start HP treatment. Indication 3 is the protein angiography consumption. We also use the modified quality subjective global assessment score. If the score more than 20 points, or the malnutrition inflammation score more than 18 points, it's recommended to start HP treatment. And these two scores, the score is high, the worse nutrition or the inflammation is worse. And the fourth indication is micro-inflammatory state. If the patients exclude the infection, the history of the tumor, the active rheumatic disease, if the patients have the higher HSCRP persisted more than 3, or the interleukin-6 more than 16.2, or TNF-alpha continue to be more than 41, it is recommended to start HP treatment. The 5th indication is severe SHPT, which is the patients, the SHPT cannot be controlled by the medical treatment. And also if the IPTH persisted more than 600, the HP treatment should be started. And the indication 6 is severe hyper-beta-2 microglobin, which means blood beta-2 microglobin more than 13, or combined with the carpal tunnel syndrome, it's recommended to start HP treatment. And the 7th indication is refractory hypertension, which means MHD patients with adequate dialysis and dry weight up to the standard use 3 or more different type of anti-hypertensive drugs. And when each drug reaches the maximum dose, the systolic blood pressure before the dialysis is more than 160, it's recommended to start HP treatment. And the 8th indication is ILS, the restless leg syndrome. If the score more than 11 points, it's recommended to start HP treatment. And the last indication is the uremia peripheral nephropathy. It is also used the score. If the score included more than 2 novel abnormalities, it is recommended to start HP treatment. And also the consensus, the second part of the consensus is recommended the treatment of great frequency. Develop individual HP treatment frequency based on the patient's complications and their severity. If the patients have the complication of the severe uremia pruritus, the consensus recommended the frequency of HP treatment for 1 or 2 times every 2 weeks. If the patient's complication with the PW or the severe SHPT or the RAS, the consensus recommended frequency of HP treatment is once a week. And also for the patients who without the dialysis complications, the consensus recommended undergo the hemoperfusion once or twice every 2 weeks to prevent the long-term complications related to dialysis. So the third part of the consensus is treatment mass. For the treatment mode, HP can combine with the low flux HD, high flux HD, or hemodiafiltration. And the blood flow during treatment, when the HP is combined with HD or HDF, it should be controlled at the 150 to 250. And also the consensus suggests the connection mass. It is recommended to connect the hemoperfusion device in serial in front of the dialyzer or filter. And the last part of the consensus is the adverse reaction and precaution. If the adverse reaction, including the abnormal biocompatibility and also the air embolism, the coagulation disorders or hypotension. And also, when the patients receive the hemoperfusion, we need to observe the vital signs during the treatment and pay attention to whether the circulation circuit has clotting or leakage. And also we need to check the blood routing and the coagulation function or the other indicators. So let's go back to the case. In this year, we changed the treatment to HP plus HDF once a week, and also the last 2 times a week HDF. And this is the HDF prescription and also the HP plus HDF prescription. And let's see the result for the patients. The evaluation of the laboratory examination shows that the hemoglobin, the calcium, phosphate, IPTH, and beta-2 microglobin and albumin were improved pre-dialysis after 6 months follow-up. And furthermore, IPTH and beta-2 microglobin were improved post-dialysis after 6 months. And also the clearance of the small molecular toxins, the KTOV, remained well. And for the quality of life, we evaluated the clinical symptoms. We can see the blood pressure pre-dialysis, pruritus, and sleep disorders improved after 3 months in treatment. So this slide shows the experience in our center to do the HP plus HDF. In the first 2 hours, due to the hemoperfusion therapies, the blood flow is a little bit low to 200 milliliter per minute, and the substitution fluid is 50 milliliter per minute due to the post-dilution. After 2 hours, the hemoperfusion finished. The blood flow increased to 218, and the substitution fluid increased to 17 milliliter per minute. And when setting the goal of the ultrafiltration, we need to pay attention. The more of the normal saline required to finish the hemoperfusion treatment should be considered. And also for the anticoagulant, we need to choose the right anticoagulant drugs and perform adequate anticoagulation because the hemoperfusion requires a high adequate of anticoagulation. So I will take the conclusion. ESRD has become one of the public health concerns in the world. The epidemiology study in China showed that an increasing prevalence of ESRD. Hemoperfusion has gradually become one of the treatment modes for MHD patients. The effectiveness of its combination with HD or HDF to remove the protein-bound toxins and also the molecular toxins and prevent long-term dialysis complications and improve quality of life, improve the long-term prognosis has been initially confirmed. However, regarding the timing of and the frequency of HP treatment, more high quality evidence-based studies still need to be clarified so as to provide a basis for the application of HP in MHD patients. And I will stop here and thank you for your attention.